Good afternoon or good morning, depending on where you are in the world, and welcome to Foundation Frontiers, a new medical education series that's hosted by Foundation Medicine. Today, I'm very excited to welcome you and to really introduce this great panel of speakers we have. I'm Holly Dilks. I'm the Senior Director and Global Head of Field Medical in the Medical Affairs Department at Foundation Medicine. And I'm joined by an incredible duo of speakers whom I'll introduce in a minute. But first, in the spirit of transparency and disclosure, here are our disclosures. This session, as you can see, is hosted by Foundation Medicine, and here you can see our additional representative disclosures, as well as on the next slide. Both Dr. Katie Wong and I are employees of Foundation Medicine, and you can also see that Dr. Szynski has his representative disclosures here as well. With that, let me introduce you to our incredible speakers, beginning with Dr. Mark Szynski. Dr. Szynski is a medical oncologist. He specializes in thoracic malignancies. He's an internationally recognized expert in the development of novel chemotherapy agents and treatment strategies for lung cancer. Dr. Szynski is the executive medical director of the Advent Health Cancer Institute, and he's served in countless leadership positions within cooperative groups and research consortia alike, including serving as the co-chair of the Thoracic Malignancy Steering Committee for the National Cancer Institute. Dr. Katie Wong is passionate about bridging the gap between oncology research and practice. She currently serves as the director of the West Medical Field Team for Foundation Medicine. Prior to joining FMI, she was also part of the medical team at AstraZeneca. Katie earned her PhD from the University of Illinois at Chicago in pharmacology with a focus on cancer cell biology. This was then followed by a postdoctoral fellowship at Tufts University. For today's session, Dr. Szynski will review the landscape of fusions in non-small cell lung cancer and really talk to us about why it's important to detect these fusions for optimal targeted therapy selection for patients. Then Dr. Wong will review the ongoing work that Foundation Medicine is doing in this arena. After this, we'll have time for a question and answer session. So anytime during this session, please put your questions in the chat and we'll be happy to either answer them live or in the chat. With that, I'll turn it over to Dr. Szynski.
Thank you, Holly, and welcome everybody. Well, you see on the slide here that our world has changed in solid tumors as well as liquid tumors, and we're much more attuned to the need for precision oncology. This slide summarizes the selected approvals that we have for gene fusions in solid tumors. And you can see we have a couple of pan-tumor with regard to RET and NTRK fusions shown on the upper left. The disease of my career, non-small cell lung cancer, kind of leads the list with 4 fusions that we look for at the time of initial diagnosis, at least an advanced stage disease at this point. And then you can see the FGFR fusion shown to the right. So the detection of these fusions is incredibly important at the time of initial diagnosis in advanced stage disease because these fusions do have FDA-approved therapies, sometimes more than one. And these are highly effective targeted therapies, but cannot be used unless you make the genomic diagnosis with comprehensive testing. Next slide, please. So this slide highlights kind of one of the more common fusions that we see, remembering that most fusions occur in intronic or non-coding regions of DNA. EML4 ALK fusions occur in 3 to 4% of adenocarcinoma of the lung. It is an oncogenic driver. You can see a normal chromosome 2 where the placement of ALK and EML4 are. With this fusion, there's an inversion on the chromosome 2, and you change this chromosome, bringing these 2 genes together, which forms an oncogenic driver with this fusion. Next slide. So with regard to detecting fusions, some tissue-based comprehensive genomic platform testing can cover mostly exonic or coding regions and some intronic regions of the DNA. Some regions cannot be, for technical reasons, be baited or sequenced. And so accurate detection and sensitive finding of the fusions depends upon the vendor's ability to detect where and whether the fusion events occur. Again, this slide looks at some of the technical reasons. If we can go to the next slide. And since some of the fusions occur in intronic regions and the DNA sequencing requires evading the RNA sequencing, may detect alterations you see on the bottom there to the right, may detect alterations within intronic regions that could be missed by DNA sequencing. Next slide. So here we have the NCCN clinical practice guidelines in metastatic non-small cell lung cancer. You can see to the left the growing list of targets, and to the right, the suggested testing methodologies. You'll notice for each one of these that NGS is included in again, I think that's the standard of care in this particular setting. But also the NCCN clinical practice guidelines do call out the recommendation that when feasible, testing should be done that includes RNA-based NGS, particularly those patients that you may not find a driver on DNA testing, but you may still be highly suspicious that this patient could harbor a fusion. So the RNA NGS will increase the yield from that, and we'll hear more from Katie about that in a moment. Next slide. So again, atypical alterations may be detectable with RNA sequencing. So the key point here is that RNA sequencing should be considered for patients that might be found to be driver negative on DNA-based sorts of things. We know that when you add up all of the fusions and mutations that can occur, up to a third of cases may have targetable driver mutations. As I previously mentioned, patients with drivers get much greater benefit from targeted therapy versus standard chemotherapy. And in general, with a few exceptions, these patients do not necessarily get a big benefit from immunotherapy, particularly immunomonotherapy in this setting. So again, the driver alterations that are detectable typically with DNA-based NGS are listed there, a list of mutations, amplifications, and fusion. But again, the take-home message being RNA sequencing should be considered for the driver-negative population to make sure you leave no stone unturned and you maximize the detection of particularly fusions. Next slide. Now, this slide lists the pros and cons for both types of sequencing. You know, historically, we've pursued DNA-based NGS, but to the right, the RNA-based NGS does overcome some of the limitations. It's important to be aware of this, as well as to be aware that, like everything, there can be false negatives due to low quality of the specimen. So keep that in mind as we go through the discussion today. Next slide. So we have a hypothetical case here. This is a 58-year-old female with newly diagnosed advanced non-small cell lung cancer. She presents with symptoms of cough that worsened over time. She gets a radiologic workup with CT PET scan. She has a lung mass. She gets a biopsy of this lung mass, and we're told that she has a good quality tissue sample. Some initial testing was done by IHC as well as FISH, and we can see that we're told that PD-L1 is negative. The ALK and ROS1 FISH testing is also negative. So what do you do in this situation? If we could just advance the slide, and obviously my recommendation, as well as I think most others, would be to send tissue for biopsy for comprehensive genomic testing. This is a relatively young woman, and you want to make sure that you, beyond a shadow of a doubt, survey her tumor for the presence of the mutations or fusions that we have shown on previous slides. So with that, I will turn it back to Holly, and we'll transition to Katie.
Thank you, Dr. Szynski. Now we'll turn it over to Dr. Wong.
Thank you so much. Thank you, Dr. Szynski. So on the next slide, as we think about this patient who's getting their tumor tested by RNA and DNA, I just wanted to review fusion detection and rearrangement detection by Foundation Medicine tissue testing. So here we're seeing 4 examples of oncogenes: ALK, RET, ROS1, and NTRK. And each of these can be rearranged to cause tumor growth. And each of these genes can have a variety of fusion partners represented by like the teal and black boxes. So for example, with ALK, it's most commonly fused with EML4, but can have other more rare fusion partners. RET is most commonly fused to KIF5B, but can have a variety of other fusion partners. And in a similar fashion, ROS1 and NTRK both have multiple fusion partners. And really, a strong DNA CGP test should be able to detect a diversity of these fusion events. So on the next slide, Foundation Medicine has really strategically designed our DNA bait set for fusion detection by taking advantage of intronic coverage, hybrid capture, as well as de novo assembly. And on the next slide, looking at real-world data where Foundation Medicine detected a fusion, and then we also looked at progression-free survival in these patients. So in the orange are patients that had a fusion detected by Foundation Medicine and then went on a targeted therapy, and we saw progression-free survival of 14.6 months. So when that fusion was not detected by Foundation Medicine, but by an orthogonal test, that progression-free survival on targeted therapy was 2.4 months, shown here in the black line. So this data is really showing that not only is detecting fusions important, but active driver fusions that will potentially respond to therapy. So the next slide really addresses, again, from our real-world database about how often these fusions would be identified. So we would predict that the overall RNA-only fusion detection rate is at about 1.3%. And looking at an enriched population of samples that were otherwise driver negative, that detection rate goes up to 4.4%. So really, in the interest of missing not one patient, on the next slide, we are really excited to have developed and launched for broad clinical use our Foundation One RNA assay, which is now readily available. So Foundation One RNA is a supplemental test to our current Foundation One CDX test. We analyze and report on 318 genes. We also take advantage of co-extraction, which means that we're able to get DNA and RNA from one sample with no additional tissue requirements. And then finally, we're able to deliver one integrated DNA and RNA report to help with treatment selection. So taking advantage of this assay on the next slide and going back to the patient case, where again, this patient was negative for ALK and ROS1 rearrangements by FISH, but Foundation One CDX combined with Foundation One RNA identified a RET fusion, making targeted therapy a potential option for this patient. So in the next slide is just, in conclusion, that Foundation One CDX is able to detect actionable fusions through a purposefully designed assay. Foundation One RNA can add enhanced detection of fusions that are not readily detected by DNA, and no additional specimen requirements in order to run the Foundation One RNA assay. And with that, I will turn it back over to Holly. Thank you so much.
Thank you. Thank you so much, Dr. Szynski and Dr. Wong. So now we'll get into a time of question and answers. And please, if you have any questions, put them in the chat and we'll be either addressing those live or in the chat. So I'll just get it started off for us. I'll start with Dr. Szynski. Dr. Szynski, in your practice, how do you use DNA and RNA? Do you think about them in a complementary manner or in a sequential manner? How do you really think about using both DNA and RNA?
Yeah, so one of the greatest things an oncologist can do, I think, is to identify an oncogenic driver, because we have targeted therapies that are highly effective in these populations, and these patients can enjoy a high quality of life with minimal side effects of these targeted agents for years at times. So I agonize over every patient that I never, 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 never want to miss an oncogenic driver. So, I think of DNA and RNA the same way I think of tissue and plasma testing. We know that no test is perfect. They have false negatives. We know that there's tumor heterogeneity in tissue. And we know in lung cancer, it's sometimes a challenge to get good quality tissue samples. Plasma testing has added to and has been established to have tremendous clinical utility in the detection of genomic alterations. And I would argue that the DNA RNA story is the same thing. Katie just showed the data to suggest that you do find things in RNA that you don't find in DNA, and you can act on them, and the outcomes seem to be superior because of the detection of a targetable fusion or mutation or whatever you may be looking at. So I think these have been incremental complementary builds in terms of how we look at comprehensive genomic testing. And I will also put in the plug that comprehensive genomic testing and covering all those 9 or 10 or 11, depending on how you count them, that is an essential part of the diagnosis. It is not okay to say someone has adenocarcinoma of the lung or non-squamous, non-small cell. You need to say they have adenocarcinoma, non-squamous, non-small cell, and no mutations or fusions were detected, or they were detected. And you want to say that with a high level of confidence. So I think the RNA story really adds to the level of confidence.
Thank you. That's very helpful to understand how you're thinking and juggling kind of all of the different aspects that go into all of this. And I think, one of the things, Dr. Wong, that you talked about a well-designed DNA assay plus RNA. When we think about well-designed DNA, what exactly does that mean in light of DNA and RNA? And how do you, why do we think about that?
I think Dr. Szynski did a really nice job kind of outlining EML4-ALK as an example and talking about those introns. And Foundation Medicine really has been strategic about designing how we read DNA to cover those introns to be able to detect those fusions. And really one of the reasons, we're so thoughtful about it is because RNA is not perfect, as Dr. Szynski was just mentioning. It is inherently less stable than DNA. So having that design and that intronic coverage to be able to detect fusions on DNA can be helpful in those cases where RNA may not work.
Thank you. Appreciate that. So Dr. Szynski, I have a question that I was wanting to ask you. Can you tell me about a case that's particularly memorable, a patient that you saw that was particularly memorable where a rare fusion was detected and there was, a very memorable change that was made?
Well, yes, I could go on for a couple hours, but I will remember one case that is particularly memorable because of the impact that it made. We cared for a lady that was originally diagnosed around 2015. She had been through about 5 lines of therapy. Now, back in 2015, she had, by today's standards, what I would call kind of rudimentary molecular testing at that time. And specifically, she had, I believe, both IHC in fish testing for ALK, and it was negative. And she had a few other things. I don't remember the details of all of this, but she went on to receive kind of standard therapy. She got chemoimmunotherapy at one point and had about 5 lines of therapy, and obviously was running out of options. And she was declining performance status. She was increasingly symptomatic. She had developed progressive liver metastases. She had developed new lung metastases, and she was a never smoker. And so between myself and my colleague, Tarek McHale, we retested her. And she ended up on NGS that was both DNA and RNA-based, detecting an ALK fusion. And here's this lady who's about to sign on the dotted line for hospice care, very symptomatic, literally has the Lazarus effect, where she gets started on a proper therapy for ALK fusions, and she has a very dramatic response. And that was 3 or 4 years ago. And this lady still is in essentially a complete response on anti-ALK therapy, not having much in the way of side effects of the treatment. But certainly, we know from the ALK experience in the ALEX trial that may live for another decade on this with the proper therapy. So, what a great story, and how wonderful is it to be an oncologist and be able to do things like that with patients. So again, our job is, right treatment, right patient at the right time, and never, never, never miss an oncogenic driver. That's why this comprehensive DNA, RNA, NGS approach is so important.
Yeah, thank you. Thank you so much. I mean, I think that's the inspiration for all that we're doing here is really thinking about the patients that, we don't want to miss those oncogenic drivers. And so as we think about, and this will be a question for both of you, I think I'll turn it over to Dr. Wong to first answer, and then to you, Dr. Cieszynski. As we think about, kind of where the field of oncology has been and how it's been moving so quickly, and Dr. Cieszynski showed on that slide the evolution of these targeted therapies. As we look ahead, let's just look ahead 3 to 5 years. I'm not even saying a decade. Let's just look 3 to 5 years. What are you most excited about, that we're seeing right now in trials, and then we're also thinking a little bit more ahead? Dr. Wong, I'll turn it over to you, and then we'll turn it over to you, Dr. Cieszynski.
Sure.
Yeah, I think something really specific to the lung space is seeing this comprehensive genomic profiling move to earlier stage lung cancers and starting to see some targeted approvals there. I think that's an incredibly exciting space that we'll see rapidly evolving over the next 3 to 5 years.
Yeah, I would agree with Katie. We'll see at the upcoming ASCO meeting some exciting new data in the stage 3 space following chemoradiotherapy in EGFR mutation positive patients. So this is just another example. We heard the Adora story a couple of years ago. We'll hear the Laura story this year. And that's what we want to do. We want to take the gains we have in stage 4 and move them into the earlier stages of the disease. But there's so much to be excited about. Again, the only thing I do is lung cancer. And how exciting is it? In the driver populations, we're beginning to understand that there are some patients that do great for years. There are some patients that don't. And who are those patients that early on need more intensive therapy, either with chemotherapy or other drugs, these sorts of things? What are the mechanisms of acquired resistance, and how can we prevent them from emerging over time and keeping patients maybe not cured, but keeping their tumors suppressed long enough so that they can live, a very long lifestyle with a very good quality of life? And then, the whole use of immunotherapy and the step up in outcomes we've seen with the introduction of PD-1 and the anti-PD-L1 agents. We're all waiting for what's the next step up after this step. We've enjoyed the ability to really, dare I say, cure patients with stage 4 lung cancer. I was trained as a fellow that, you have a treatable disease, but you don't have a curable disease. And I think that's changing. And I have a growing number of examples in my clinic that I parade around to everybody, because these are people 5 years out, no evidence of disease, having received chemoimmunotherapy typically. And we just never saw that in the chemotherapy era. So the era of immunotherapy and targeted therapy in molecular detection really has been a huge change in the approach to lung cancer. We should look at this disease as with a great deal of optimism, where historically there's been a great deal of therapeutic nihilism. That has changed 180 degrees.
Yeah, I agree, and I really appreciate your perspective on that. I think, looking ahead to the future, it is brighter skies than maybe we even thought they would be, in the past. And your optimistic perspective is a great place for us to end this session, thinking ahead to everything that is to come. So I want to thank everyone for joining today. Especially want to thank Dr. Cieszynski and Dr. Wong for sharing what they did. And we'll see you the next time on Foundation Frontiers. Thank you very much. Have a nice day.
Thank you.